Morning, George. Great to see you. It's another Tuesday morning. I'm in Ocean City, Maryland today.
How are you? I'm Dr. Rogu from the Pediatric Lounge. Today, Dr. Bravo, welcome Dr. Anya McLaren. What is her topic today, Herb?
So, welcome, Dr. McLaren. Dr. McLaren is going to join us to talk about a reach-like project for coaching sleep coaches in pediatrics. How are you, Anya?
I'm doing well. Thanks. Thanks for having me this morning.
We usually start all our episodes, and for our audience, Dr. Anya is a Canadian-based pediatrician. And so this is our first international guest. We have a lot of people that listen to us overseas, but we have not had the pleasure of having an international pediatrician. So this is the first of the podcast. It's a joy to have you. We always start with, why did you become a pediatrician?
Sure. So I think, my the desire to pursue pediatrics sort of started out in high school when I had exposure to working or volunteering actually as a member of the UNESCO club in my high school at a child orphanage. As I progressed through my medical education and training, being on pediatric rotations, I found I was most inspired, most, joyful. So it was almost a natural progression to pursue pediatrics after medical school.
Wow. And you're a respirologist, which is interesting term. In the US, we call you pulmonary docs.
Yeah.
And so I'm very curious because you're also a sleep doctor, a pediatric sleep doctor.
Yes. Yes.
So how does it happen? I understand you grew up in Jamaica, then you
Right.
went to medical school in Toronto,
Yes.
then you went to Children's in Toronto, which is a great international facility.
Yeah.
Once you finish your residency, did you take an exam like we do in the US? We call it the boards to prove that you actually learned something in the 3 years.
Yeah. So we have, it's called MCCQE, which is basically an examination that every physician who completes their medical training has to complete in Canada in order to have a license to practice medicine. And this is before we go into residency training. And then once we've completed our residency training, there's a Royal College. So Royal College and Physicians of Canada is our sort of governing and licensing body.
This exam is 2 days, proctor exam, or
Exactly. The pediatric licensing exam, after we finished our pediatric residency training, it's a day-long exam, including both type assessments as well as our written exams. We had a written exam on one day, and then we had our OSCE exam on another day. We get standardized patients, and they're examining us in the room, and we're given a STEM, and we have to perform what that STEM asks or requires of us.
after how many years do you have to repeat that exam?
So currently we have a continuing medical education program with our Royal College. So we don't have actual standardized examinations, but in order to maintain our license as a physician or a pediatrician or to continue practicing, we have to complete a certain number of continuing medical education type.
So
Uh,
I'm going to interrupt you, and I'm going to be a little.
yeah, sorry.
So I think that Canada is a little bit more socialist than America, the US. But
Yeah.
don't require their doctors to go back every 7 years and do another exam to prove that they know what they're doing.
No, we actually do not have that type of
Wow,
assessment.
wow.
Yeah, in Canada.
Canada doesn't regulate their doctors like they're all buffoons, like the US does.
We don't.
Wow. Well, then after you finished the pulmonary fellowship, did you have to
Right.
take another exam?
So our respirology exam, we did, yes, after respirology training, we did another examination. And then for sleep medicine, it's our sleep medicine training is more an extended scope of practice. So we have to demonstrate proficiency in seeing a certain type of patient and a certain number of those patients over the year-long training. And then we also have to complete interpretation of a certain number of sleep studies. So we don't have a formal exam for that.
Oh, wow. And,
Yeah.
and the residencies for pediatrics in Canada are like in the US, 3 years.
Our pediatric residency program is now 4 years.
Yes.
And that was, yes. So you have to complete 4 years of pediatric residency. But if you end up going into a subspecialty like I did, respirology or pulmonology, the first year of fellowship counts as that 4 year part of that 4 year training. And so
Okay.
I completed 3 years of just general pediatrics, went into pulmonology, which was a 2 year program or training, and then into sleep medicine. So in total, it ended up being 6 years. But currently what they've done is recently is that pediatric training is now a 4 year program. And so you are not allowed to overlap your first year of subspecialty training with your pediatric residency.
So what do they do in that last year of training? Because 4 years sounds like a lot.
Yeah, so I mean, right now our total is a competency-based curriculum, and so instead of having as the standardized type of assessments that we've had before, what ends up happening is that after every rotation that a resident completes, we have to do formal sort of evaluations, and we have a big committee. We meet regularly to review and evaluate those residents, and so I suspect that because of the way that the program has changed, it sort of lends itself to a bit more time, having the residents go through that sort of curriculum.
Is the first year a rotating internship through different specialties of medicine or straight pediatrics?
There's a lot of inpatient sort of CTU or general pediatrics on the ward throughout most of the years, but there is, and it depends. Certain residency programs will have the first year where it's primarily general pediatrics. And then when you get into second year, it ends up being a lot of subspecialty rotations, which is the program that I completed at the Hospital for Sick Children. So the first year was completely sort of all general pediatrics in the community as well as in the hospital or tertiary care, quaternary care setting. And then once you've completed that, the second year is primarily subspecialty training. In the third year, you had opportunity to do electives, in the areas that you were interested in.
And so now is the pulmonary fellowship, a respirology fellowship 3 years or 2 years?
It's still 2 years. Yeah. Yeah.
Two?
Still 2 years.
Oh, two?
Yes. Yeah.
Yeah.
Two.
In the US, it's 3.
Okay.
How much of that time is devoted to research?
I think it varies the pediatric residency programs that do have pulmonology as a subspecialty are not, it's not in every pediatric residency program across Canada. When I trained at Hospital for Sick Children, everyone had to complete a scholarly project. And that was sort of done in addition to the clinical work that you were doing, but you had to demonstrate some competency in performing research, a research project. As far as I remember it being sort of specific time that was allotted to do that. But you definitely did have electives that you could do research on, but you definitely had to complete a scholarly project over those 2 years.
Oh, well. And so here it's 3, and I think something like at least a year or 18 months is dedicated to bench research.
Oh,
Um,
I see. Yeah,
and
it's not
so
like that in Canada.
yeah, and then they have to take
Yeah,
the board exam, and they got to repeat that board exam every 7 to 10 years to qualify as a
right.
board certified respirologist. I wasted money and time. And so you did all these great things. And what is like through your residency program? So I'll level set because it's a little different. But in the U.S., for example, the average family of 4 makes 50,000 a year, and
Mhm.
pediatric resident will be lucky if they get $40,000 a year to $50,000 to do residency. In Canada, are residents used as kind of like indenture labor too?
Yeah.
Like, they're not paid a fair wage through all these 7 years.
Yeah, so I would say, I mean, and I cannot remember sort of what the exact numbers were. I mean, you know, since I went through my training and currently there's a lot that has changed to preserve the, I guess you call work-life balance of our residents. So, when I was going through training, we had 24-hour on-call shifts. No, they're 12-hour on-call shifts. And typically, staff are pretty good at getting the residents out after the completion of those blocks. You know, I mean, that rotate that time block. No, I would say a resident in Canada makes enough money to sort of live independently, likely contribute towards repayments of their, medical student loans. And I mean, I remember when I went through residency, it was I felt that I had enough to sort of live independently, and again, the work-life balance that I was going through is
Yep.
probably a lot better now. But there were definitely efforts and always have been efforts by supervisors to, help preserve that work-life balance among residents, get them out on time. So it's pretty reasonable, I think.
So just so you can laugh, when George and I went to residency, there were no limits. So we were basically on every third night for 36 hours on a row. And
That's every fourth.
And well, we did every 3. And they would call you in if you wanted to see an interesting case coming to the PICU and go on the helicopter. And I started making $25,000 a year in 89, which was, was nothing. I mean, it's what, a clerk at a restaurant would make.
Yeah.
And so it's
But not
interesting.
in 89.
I think in 89, that's what a level entry job was. But anyhow, and so do you have a problem? Not you personally, but the Canadian physician, do they have a problem with student loan repayments?
I would say when I went through medical school and I took out a line of credit for my medical aid, was told that within the first few years of practicing, most residents or most physicians are able to repay their loans.
Okay.
And so my general sense is that within 5 years of completing training, we are able to sort of complete the repayment of our loans. I think one of the differences between Canada and the US is that our medical tuition is fraction of what it is in the States. And
Okay.
so that definitely helps with the repayment. So when I actually entered the University of Toronto as a medical student, and to give you just an idea of, because the international student tuition was $50,000 Canadian a year, the domestic rate was something around 20 to 25. So, and it ended up, I think, and I would say University of Toronto is probably one of the more pricey medical schools in terms of tuition. I don't know what the figures are now, but I think that lends itself to, less issues with repayments once we're out and, staff position.
And as far as choosing a specialty, you had a passion for pediatrics because
Right.
what you saw in Jamaica, and that's
Yeah.
your
Yeah.
calling, right? Which is what
Yeah.
it should be. In the U.S., the pediatricians are the lowest paid, and some don't even consider a specialist. And the divergence is appalling. So in
Wow.
US dollars in Michigan, a starting pediatrician will start out 120,000, while anywhere in the country you cannot recruit a radiologist for any less than somewhere between 350 to half $1 million.
Oh, wow.
Is the
Yes.
disparity the same in Canada?
Yes, there is that similar disparity. So I remember when I was in medical school, we had a list of uh, starting salaries for different subspecialties. And I think pediatric psychiatry and family medicine were at the bottom of that ladder. And
Okay.
at the top, as you pointed out, radiologists, general surgeons, in general, adult subspecialties and adult, physicians get paid. I would say probably twice as much, if not more, than pediatricians.
Not 5 or 10 times.
I don't think it's as, it also depends. There are pediatricians who go into practice and only work part time. But if you were to compare a full time pediatrician in the community to a full time, gastroenterologists here do pretty well, then it probably is more than two times. Maybe three to four. I don't suspect it's as much as 10.
Right.
Yeah. Yeah.
And
The
because
disparities are because the specialists all do procedures, and in pediatrics, there is no procedure. So it's all evaluation and management, preventative care visits. There's no procedure.
Right.
If there was one
Right.
procedure that peds could do, the income would be much higher because
Yeah.
the way that the system is rigged, they pay for procedures.
so
Yeah.
so I
I would say for pulmonary function testing and pulmonary function test interpretation, if you compared an adult respirologist to a pediatric respirologist, I think they still probably do better from a financial compensation perspective because the rates, in Canada, our salary comes through the government. So, there are certain rates that have been set for compensation of uh, our work. And basically, the rates for adults are higher than the rates for pediatrics.
So it's not the procedures like it is in the US. So walk me through this because I did my medical school in Costa Rica and they're socialized, totally socialized medicine. And the
Right.
pediatrician makes as much as a general surgeon
Oh,
because
wow.
they have a government schedule and they almost all work for the government. All
Right.
physicians work for the government. All hospitals are owned by the government. And so they will have something similar to in US with called GSA schedule, which is the federal
Mhm.
government. So if you have high school education, you're step one. If you have a
Mhm.
doctor's degree, you're about step 14. If you have postdoctor training, you're at step 15. And so
Right.
the surgeon would make more than the pediatrician because they were started out the same place, but the residency was 3 years for the pediatrician and 5 for the surgeon.
Mm,
And so
mhm.
they started a higher salary because of those 5 years of post training.
Right. Right.
Is how do they do you said that the pediatricians get paid less, but how do they is there a base? So I guess what I'm asking, if you passed your 4 years and you join a clinic or health system in Canada because you're employed by the government, is there a minimum salary that pediatrician is gonna make?
No, there isn't a minimum. It's fee for service, which means you get paid or compensated the amount that you actually, based on the number of patients that you actually see.
Oh,
I know recently that there are community health clinics that the government will fund on a salary based basis. And so I'm not sure sort of what the compensation or base salary is for those pediatricians in that sort of setup. And definitely when you're in a tertiary care setting, the government will give the hospital a certain base salary for the pediatricians that are employed in that facility.
okay.
And then you're always in a tertiary setting affiliated with a university and you do get some sort of salary from that perspective. But if you're in the community where I was shortly after I finished my training before I went to tertiary care set, you get compensated based on the number of patients you see. So if you are sick or your children are sick and you have to, miss clinic or cancel your clinic, you will not be compensated. So it really, if you have no shows, you will not be compensated. And so it
Okay.
really depends on the number of the volume of patients that you see.
What does community pediatrics look like in Canada? Is it all by pediatricians or is it some family practice or some GPs? I don't know. I don't
Yeah,
know if you have GPs in Canada.
it depends. So when I was in Toronto, so Toronto has a very dense population of pediatricians. So pediatricians do primary care in addition to consultations. Where I am currently in Hamilton, which is outside of Toronto, it's there. Some pediatricians are less common, and so a lot of primary care is done by family doctors and pediatricians are consult only. And it varies depending on where you go in the country, but definitely it can be a mixture of both or primarily just hospital type CTU work as well as consultation in the office or community setting.
So if there are no pediatricians available at the community level, is so I have to refer back to Costa Rica. In the US, this is not
Sure.
allowed. But in Costa Rica, you could finish medical school, do a rotational internship, do a year community service, and you have a license as a general practitioner. No more training. They have a family practice track that's a 3-year residency too, but they're a step above the general practitioner. Are there general practitioners in Canada, or does everybody have to go through residency training in some form?
Yes. So we do have family medicine physicians who complete medical school, do a 2-year family medicine training program. And then they will see, they're sort of like a general practitioner. They see they see both kids and adults. So everyone across the age spectrum. And so, but they still have to do a residency
I see. Okay.
in family medicine. So, you know, family medicine physicians do see a large population of kids, especially kids that are otherwise healthy and well.
Okay. And so the vaccinations are in a community like the one you're in right now, there's not a
Mhm.
lot of community pediatricians, will almost all be given by general practitioners.
Exactly. Exactly. Yeah.
And
Yeah.
and is the vaccine funded by the government, do you know?
Yeah.
Or okay, so
Yes.
the vaccines come from the government and the doctor probably gets an administration fee or some
Yes.
visit fee for that. Okay.
Yes.
All
Yes.
right. So,
What is it like in the States?
well, in the States is really awful. So there are 2 different programs. There's those for kids that have private insurance, and 52% of our kids now live or near the are at or near the poverty line. So they're covered by an underfunded program called Medicaid, which is a partnership with the federal government and what you would call the provinces or the states. And they provide the vaccine serum, and then they pay the private pediatrician to administer the vaccine. But the insured population, you bill the insurance and then they reimburse the practice for the vaccine.
I
And
see.
it's very complicated, very cumbersome.
Mm,
And
mhm,
the Medicaid service is woefully underfunded. So in
mhm.
some states, it pays 50% of what they pay for an adult patient for the same visit. And
Wow.
for example, in my state or province for the Canadian audience, 50% of pediatricians will not accept Medicaid because they can't afford it.
Mm,
Okay.
mhm,
But there's not the
mhm.
same rate for everybody. It just depends what insurance you have. It's a total mess. Right?
Sure.
What do you think your residents coming out if they went to a community pediatrics job would start at?
Yeah, I mean, again, it will depend on the volume. I mean, I know of some pediatricians who probably bill, you know, anywhere between 150 to 200 Canadian.
Okay.
I mean, for pediatricians who do combine their work in the community with being on call at a hospital in the community, if they're doing 24-hour or 12-hour call shifts, and again, depending on, if there's a night where they're having to attend 10 deliveries, you could walk away from an overnight call shift, billing anywhere from five to even $10,000 just for that call shift.
Oh,
Yeah,
wow.
And so,
but you just said 5 to 10 deliveries. Pediatricians
yeah,
don't
well,
do that
in
anymore.
combination with a lot of other things. So like any, babies who you have to admit to the NICU, or if you had to do an LP on a baby who came
Yeah,
into
that's a lot of
emerge.
work.
So yeah, yeah,
So
no,
work.
it definitely. I actually I did work at quite a busy hospital in towards the latter year and towards the end of my pediatric residency training program or respirology training program. It was busy. And so, but you can feasibly and very easily bill anywhere between 5 to 10,000, depending
Oh,
on the volume. So you're going to be the hospital pediatrician for emerge, for the NICU, for labor and delivery. There's also a post emerge clinic that runs throughout the day, and so it's quite busy. And then, so depending on how many call shifts you're doing in addition to your community work, you could potentially bill more than sort of 150 to 200.
Yeah, but
and
that's a lot of work.
Yeah,
Most
no,
doctors don't want
definitely.
to do all that work.
no,
It's a lot of work, yeah.
I'd stay away from generalizing. Um, in Costa Rica, that is the model. So almost every pediatrician that goes through their children's hospital will join a community hospital and do what you're saying, call shifts. And they'll be
Yeah.
responsible for the ward, the delivery service, the emergency room, and stabilize the kids and send them to the National Children's
Mm,
Hospital. And then
mhm,
they work at a hospital owned clinic for
mhm.
consultations, or they'll do that and then they'll have a private practice where they get paid cash to see the.
Right.
In some ways, up to the age of 50, I think that's the best model because you keep your
Mhm.
skills by still going to
Yes.
the hospital. I mean,
Yeah.
I don't know that I could do it every fourth day anymore, but
Mhm, mhm,
once a week, I think I could have lasted for a while.
mhm.
You have your skill sets. Well, right now, for many of the US based pediatricians, we don't even attend the hospital, not even the normal nursery.
Mhm, mhm.
It's either community or hospital based. It,
Okay.
and neither side is doing well financially. And there's a shortage of both community and specialists.
Oh,
So now
wow.
I have one. Thanks for sharing all of this. It's fascinating
Yeah.
from a policy point of view, to see what just across the border, right? We're
Yeah, yeah.
pretty much the same country, but that's going to offend some people. But we speak the same language except for the Quebecois, and we share a lot, but we're so different in so many ways. And I have an off the wall question for you. What
Sure.
what what led you to leave Jamaica and the beaches to go to the cold winter
I
in Canada?
I know,
I
I
mean,
know.
you fall off a bike as a child or something? I mean,
Yeah. So when I completed my high school education, I had the opportunity to attend on scholarship a university in North America, and I or Canada, and I was pretty sure I wanted to do medicine. In Jamaica, we go directly from high school into our vocational training. And so I ended up, being wondering if there was anything I was missing out, or if I did commit to a program, that was, you know, in Jamaica, the medical school training is about 7. And so I wanted to get exposure to what else existed. I thought about physiotherapy or kinesiology, and it, I had two sisters who were also going away at the same time. And so it seemed, you know, I'd come abroad, get my first degree, and then I could always go back home if I wanted to. So I think it was a combination of me wanting a bit more exposure and wanting to be 100% certain that I was entering into the career that I really wanted to be in.
oh wow. That's, having come from overseas, we have a term for that in the mid-developed countries, which is brain drain. You know,
Right.
um,
Right.
the most talented people go away on scholarship and never come back. Now, you have an interesting program, and I've coined it the REACH program for sleep coaches.
Yes.
The reason why I coined it that way is because we have something called the REACH program for mental health that
Mhm.
run by psychiatrists for pediatricians to help us manage anxiety and depression in the offices because we have so much of that. Why do we need a REACH like program for sleep coaches?
There are many reasons. I mean, sleep coaching is where I started, but my plan is to really sort of capture all professionals who interface with children in the medical care setting or healthcare setting. Primarily because sleep is the primary activity of a child. So between in the first 5 years of a child's life, they actually spend more time asleep than they do awake. And then beyond childhood into adolescence, it's about 40% that they should be 40% of their total brain in a 24-hour day period that they should be sleeping. Despite sort of these facts that we know, the medical education around sleep and sleep health is very poorly sort of represented in the medical curriculum. So, there are some studies that came out of the States a few years back that showed that a physician or in medical school, medical students on average are getting about 17 minutes of education on sleep health. I know definitely going through my medical school here, there was not a sleep sort of curriculum. And in pediatric residency training programs, though there is some variation with some programs having about 10 to 11 hours of sleep health training in their 4-year period. Most programs do not have that. And so I think it's a big miss on our part because what the data also shows is that primary care providers, nurse practitioners, as well as family doctors and pediatricians don't feel confident in recognizing and identifying sleep health issues. And then because they're not sort of able to identify them, they definitely can't really do anything from a management perspective. And so we know that children who don't sleep well as children continue to not sleep well when they get into adolescence and it continues into adulthood. And we know from adult data that poor sleep health increases the risk of mortality and a lot of comorbidities along with that. So I really think that we can do a much better job educating our medical professionals on, sleep and sleep health issues. But sleep coaches, they are not sort of medical professionals per se, but what I've learned is that because parents go into their pediatricians or family doctors' offices and are not able to get their sleep questions answered, especially for the newborns, they end up seeking support from these sleep consultants or sleep coaches. And when I looked into the way that the sleep coaches are trained, their training is done by fellow sleep coaches who sort of been, doing that work for some time. And there is no training around how to recognize or identify potentially, medical related issues that, need to be actioned. And so some of these medical conditions can present very similarly to the behavioral conditions that mostly is what we see in children, and their sleep. And I think that is also a big miss on their end, to not be able to recognize and help support families to advocate and actually educate families about seeking help for sleep issues. And so I'm confident that if we're able to educate people around how to identify these issues, it will impact the current rates of sleep problems, which the CDC has estimated to be anywhere from 30 to 70%, depending on what you look at. Inadequate sleep, poor sleep quality, but it's estimated that at least 1 in 3 kids are not getting the sleep that they need.
So I'll go back to that in a second, but I'm
Sure.
struggling with the idea. I think we have too many coaches. You have a lactation consultant. You got to have
Right.
now a sleep coaching for the newborn. Well, newborn sleeps 18 hours a day.
I have a feeding
Mhm.
coach.
You have to, nutritional coach, you know,
Right.
your gym coach, your coach so that you can stay on task at work. Are,
Yeah,
are we overcoaching people? I mean, how did people do it before up in the bush in Africa or in
I
the
know.
in the
Yeah,
little town in Colombia where there's no running
yeah.
water and they still raise their children?
I know. And definitely, when I first got into sort of looking at this issue, I have read around, this exact, question, which is, that and what the sort of general sense is that pre sort of industrialization, and even in countries that have more of a village setup to help with raising children, there are many people around to support a child. I mean, the way it is, but in North America and in other industrialized and, sort of setups, that village doesn't exist. In a country where you have maternity leave only being 6 to 8 weeks and a parent having to get back to a job and to be productive at that job, it definitely sort of poor sleep because of a parent, because of a child that is waking up frequently, or if there needs to be help with feeding, etc., ends up impacting that family and ends up impacting the productivity of that
You're touch
parent. And
you're touching on something that we talk about a lot, which is
yeah,
relationships in the neighborhood. And
mhm,
as we have lost the relationships in the neighborhood, you know,
yeah,
it's not like the village where the grandma and the aunt are around,
right,
you
right,
know,
right,
and
right.
they say, no, 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 you don't pick up that baby at 3 in the
Yeah,
morning, feed him, honey.
yeah.
You'll never get any sleep.
Yeah.
Yeah.
I mean, I would argue as well that in the other countries where, you have grandmothers that have raised, many kids and
Oh,
then go on to raise grandchildren, they're probably the equivalent of a sleep consultant in terms of,
yeah.
having a really keen sense about, when things are not normal and,
Yeah.
being able to really sort of support their children through those times. And so I think that we call them sleep consultants or sleep coaches now, but in the countries where they're not sort of formally, they don't go through any formal training or certification program or don't have that title. I mean, that's basically what they do
Yeah.
and what has been done for many years. I think
Well,
we've lost out on that in sort of North America, Canada, and other countries.
in the areas of the world where the grandmothers are still involved are smarter than the pediatricians. I mean,
Yes,
just
yes,
the other day in clinic, I had a mom come in because she thought the baby had chicken pox, and she said, "My grandmother said this isn't chicken pox." And I looked at it, definitely wasn't chicken pox. I said, "Yeah, you should have just listened to your grandmother because she's probably
yeah,
seen more chicken pox than the average pediatrician, in the
yeah,
U.S., Canada."
yeah,
Yeah.
yeah,
I
yeah.
used to use, I remember in the early years before I had children,
Mhm.
case would come in for whatever, and I didn't know what the heck was going on. And they're with the grandmother, say, "Hey, grandma, what do you think?" And
Right,
grandma would give me
right.
the answer
Yeah,
because I
yeah,
had no experience.
Yeah, I mean,
exactly.
20 kids,
Yeah.
so
But today's moms, they don't believe what the grandma says. It's it's changed since you were a mom, boomer.
Yeah, yeah, yeah,
yeah. And so, how are you going to try to change this? Especially, I'm really concerned about these coaches that have no formal training, and
yeah,
you
yeah,
know, I'm gonna get myself in trouble, but it's in the U.S. It's like the nurse practitioners. As long as you know the limits of your knowledge, you can
right.
be very helpful. The
Yeah,
moment you overstep the
yeah,
limit of your knowledge, you can
yeah.
be very harmful. And that
Yes.
applies to me too. I'm not going to change a child's medicines for
Yeah.
epilepsy. I don't do that. I'm
Yeah.
not going to adjust your heart medicines on a kid with congenital heart disease. I'm
Yeah.
not trained to do that. That's
Yeah.
why the pediatric subspecialists exist. I'm regulated. These sleep coaches are not regulated. They're being paid
Right.
cash, and they have an incentive to get you to feel what's the word I'm using for not confident, so you use their services more.
Yeah. Yeah.
Very
Yeah. Yeah. So, I mean, when it comes to the question of scope of practice, I think it has to just be very clearly sort of communicated. And I think most of them do have a general sense what is within and outside their scope of practice. Of course, this is a general statement, but I mean, I think what the program that I've created does is really sort of educate on the most basic level, because the other thing as well is that there's no real prerequisite to become a sleep coach or a sleep consultant. And so, you have sleep coaches or consultants who have, there are nurse practitioners who end up doing certification programs, some of them. And you also have pediatricians who do these sleep certification programs. But then you have individuals who may not have completed high school, who end up being nannies, for example. And so it's such a huge mix of individuals from different educational backgrounds. And so what my program aims to do is to, at the most basic level, we provide some education around what sleep is and what potential sleep issues could look like. And basically, my program doesn't sort of extend the scope of practice of a sleep coach. It sort of educates them and then says, if you do encounter these issues, you should advise your child to seek medical attention, and you should not sleep train them through these issues, because I find that oftentimes, well, what I've found is that when a child is difficult with the process of sleep training, a lot of sleep coaches will continue through and push through when potentially there is a medical issue at hand that you could be missing. And so I really, the goal of the program is really to educate sleep coaches about what, you know, can present and can look like behavioral sleep issues, and really sort of encourage and advocate parents to seek, medical attention, and talk to their family doctor or pediatrician about it.
Yeah, you're absolutely right, because the sleep, if you look at sleep, people with anxiety and depression won't sleep well, but their
Right.
anxiety and their depression won't get better until they sleep well.
Exactly. Bidirectional relationship. Yeah. Yeah.
People with nutritional problems, obesity, they often have disorganized sleep too, and
Yeah.
until you get them into a regular sleep habit and a
Yeah.
regular exercise habit and good
Yeah.
nutrition, you can't move either one. They're
Yeah.
like
Yeah. Yeah. And I think the difference with
family dynamic,
children.
the family dynamics. If you have a kid that
Yeah.
genuinely
Exactly.
doesn't sleep, it
Yes.
will wreck the marriage. It will wreck
Yes.
your job. It will
Yes.
destroy your family unit.
Yes.
It's a
Yes.
total disaster.
It's a disaster.
And
And
it's
what?
bidirectional, because you don't
Yeah.
care. He wants to sleep in my bed. I'm going to get 4 hours of sleep. I don't care. 4 hours is
Yes.
all I'm going to get. I'll do whatever
Yes.
he wants. I mean, I mean,
Yes.
the little baby, right?
Yeah.
Uh,
Yes.
extremely important for our overall well being.
Yeah. And what the data has shown is that babies or infants who are born into families with lower socioeconomic status or low maternal education, children or infants who are watching at least 1 hour of TV per day their sleep is impacted from those factors. And I think with children, the difference between children and adults when it comes to sleep is that children don't have control over their environments, and sleep is it's sort of that combination of nature versus nurture, as many things in medicine are. And so the environment that a child is raised in and that a child exists in definitely impacts, their sleep. There's data around older children looking at the impact of racism and how that impacts sleep. There's more data, I would say, in adults on that topic. But I think just, and the program for nurse practitioners and physicians, which I'm going to, in the process of developing as well, is going to really sort of delve more into all the factors that affect and contribute to sleep, because I think recognizing it, is really the first step. Because as much as, we can educate families and educate parents about what these factors are, I think it will definitely sort of impact the child in the long run. What the data also shows is that parents don't know much about sleep, and what is a lot of parents accept sleep that is fragmented or sleep that is reduced in numbers as normal, or this is just a part of parenthood. We find it especially in parents of kids with autism or parents who are on the neurodivergent spectrum, that my child sleeps poorly, and that's just the nature of this condition, and that's just how it is. But this is actually not necessarily, it's not true. There's lots of data on behavioral interventions for children with autism and ADHD that have been shown to be effective. I know that when medical residents come through our pulmonology or respiratory medicine division, their sleep health knowledge is sort of, at most basic level. And we're basically educating and graduating generations of pediatricians who do not have any ability to really support a family through sleep issues, which I think is a real big miss.
Yes. And so let's focus right now just on what you have developed right now. So it's just for sleep
Sure.
coaches.
Yeah.
And
So,
and what
so
does the program look like right now? What you
sure.
have out right now?
Yeah, sure. So the program that we've created is for sleep consultants at this point. We are working on a version of that for nurse practitioners next. But currently as it exists, it's a one-on-one, well, not one-on-one, sorry, group coaching type of program where there's a curriculum of 12 modules that basically takes a learner from the very basics of sleep, and it sort of builds on the concepts as it goes through. we look at behavioral sleep issues, behavioral interventions, non-behavioral sleep issues, and sort of how to navigate those in terms of recognizing red flags and
Okay.
recommending that families seek medical attention. And then we've created a proprietary sort of algorithm that takes a sleep consultant from, the very as a child's sleep concern through an iterative process. So basically you have an input, which is what the parent will tell the sleep consultant, and it takes them through iterations of what to ask and what to look for. And then it ends with recommendation or an output. And so that is for both sort of 0 to 1 and then 1 to 5. The program is actually focused on kids between 0 to 5. These are the kids that mostly consultants end up working with. And then there is an assessment at the end of the program, which runs over 4 to 6 months. And at the end of the program, the hope is that a sleep consultant who has come through now has the ability to have more of a comprehensive background on which they work with families and are now able to not only recognize but educate families about how to support their child's sleep health. It's completely evidence based, and so it's created using sort of high level evidence we do have available around sleep. So mostly systematic reviews, randomized controlled trials looking at sleep health in children. And there is a bonus module where I actually try to, teach a sleep consultant how to evaluate any data or evidence they come across. Again, through a very sort of simple process. And so that program, I decided to do it as a group coaching program because I wanted to sort of ensure that the individuals who come through the program are really sort of clear on the concepts and clear on the education that is provided. And that group coaching.
Sorry to interrupt, but they also are going to have community because you're doing it as a group. So
Exactly,
they've shared
exactly,
experiences and they're going to be able
exactly,
to coach each other. And maybe
exactly.
if it works great, they'll go on and have relationships that they can share with
Right,
each other in the future, which is the
right,
magic of mastermind groups or coaching groups.
exactly.
Yeah.
Yeah.
It's
So
share knowledge. You
yeah,
know,
the
I
the cohort that I'm currently working with, there's a sleep consultant who is an occupational therapist. So she actually works in the NICU, in a tertiary care setting, and she has a practice where she works with kids who have sensory related issues, and that obviously impacts their sleep. And so we have her expertise in the group. We have individuals who have been in the sleep field working as a consultant or coach for 16 plus years. And so we have that experience to draw on as well.
and
So
so
it
this
really enriches the group.
is this program open only to people in Canada?
No, it's not. So we
No.
actually have sleep consultants in the UK, New Zealand, Canada, and North America. So it's a international global program.
So I'm going to ask something really stupid. So as long as you
Yeah,
speak English, you can join the sleep program.
exactly.
I'm
Exactly.
imagining you run it in English, not in French. So
Yes, no, it's run in English. Exactly.
okay.
And so
Um,
sorry, go ahead.
what does it cost to go through the 12 modules?
Sure. So our current beta launch pricing is 3,000 US dollars. And
Right.
so we've set up an installment plan where sleep consultants can pay over a certain time period. And so we, yeah, so that's what the beta launch looks like. When we do go through the first launch, the pricing may differ, but for now, that's the current cost.
And how many participants can you take on at a time? I mean, you got modules, so it must be a rolling subscription,
Yeah,
right? So
exactly. Yeah.
and you also have a full-time job, so you can't do this all the
Right.
time. So how many
Right.
how many people do you take into a new class and how often?
Yeah, so this is the first run of it. And so it really will inform what we do in the future. Currently, we have about 11 sleep consultants in the group,
Okay,
and it's pretty manageable. So we'll see how it goes as we get further into the program.
great. And then where do people find out about you and this coaching group?
Sure. So it's thesleephealth.org is our website. And, if all the information is there, including a breakdown of what each module covers, how to sign up or join our wait list. And our next step is really to provide some version of this for nurse practitioners who, have also demonstrated an interest in learning more about sleep. Nurse practitioners in Canada, we have a lot of nurse practitioners in our hospitals who support physician teams, and so any nurse practitioner who's interested in learning more about sleep and sleep health and how to support that in a family, they can also visit our website and sign up because we will be making announcements shortly about what that will look like.
Is
Great.
this organization like a private organization or is it some academic center backing it?
Currently, it's a private organization.
I like that.
And so we'll put the link to the website on our show notes for those who are interested in going there
Thank you.
and looking into it. So we'll also do it on our YouTube channels.
I have one question. So
Yes.
Sure.
it looks like the purpose of this is to teach some professional how to do sleep coaching. So they have to pay for training, certification, and so forth. What is their return on investment? Because I don't think there's a procedural build for this. I guess it's an office visit.
Yeah. So, I mean, when we talk about medical professionals, for sure, it will expand the scope of a nurse practitioner's role. So, nurse practitioners, as you know, can see patients independently. And so, being able to have a tool that takes them through an assessment for a patient with sleep issues, will expand their scope and allow them to create a bit of a niche within their practice. And so that is somewhat of an incentive, I would say. For pediatricians, it also in Canada anyway, and I am sure in the States, you can actually, I mean, doing a sleep consultation is something that is not very hard and sort of very simple to do. And my hope is that any pediatrician who comes through this program will leave feeling confident to be able to actually start seeing sleep consultations, you know, in Canada. And I'll speak specifically to Ontario, the wait time to get in to see a sleep physician is over a year. And I mean, these are for issues that are very sort of simple and easy to solve at the primary care level. I mean, a child who needs a sleep study will have to see a sleep specialist, but I would say that a fraction of the referrals that we get are actually for kids who need sleep studies or kids who end up having sleep apnea, or any other type of sleep disordered breathing. And so, what I hope this program will do is really empower medical professionals to take on or see children who have sleep issues and reduce the wait times that we currently face and get kids sleeping well because it's a foundation of their health.
But these coaches are doing it for cash, right?
So the coaches, I think, are, the coaches, yes, so you're right. The coaches do this for cash. And so my vision with the sleep consultants and the sleep coaches is that, and I sort of view them as supporters of the work that physicians do, because if they're able to really identify the kids that do need the help and support from a physician, then that for me is a real sort of public health good. And it definitely can change the trajectory of a child's life, because there is data to show children who go with untreated sleep issues have a greater likelihood of carrying those sleep issues into adolescence and adulthood. And so if we can change that path or trajectory of a patient, whether it's a paid service or not, it goes a long way for that parent, for that child, for that entire family.
Yes. It can get expensive though. In my neighborhood in the suburbs of DC, if you want to
Yeah.
see a psychologist, a PhD in psychology, none of them take government insurance. None of them take private insurance. And
Yeah.
the price range is between $185 an hour to 250. So think about you have an adolescent with anxiety, you got to shell out
Yeah.
$200 a week for 6 months. That's
Yeah.
that's a real problem.
Yeah, I mean, and I'm quite aware of sort of that. I'm aware of that. And one of my hopes is that, you know, other allied health support professionals will see the value in adding sleep and sort of sleep health education and knowledge into their tool belt or toolkits, and will be interested in taking a program like this where they can provide more affordable access to services. So, in Canada, for example, social workers who and there are many social workers who have gone into sleep training and sleep consultancy. There is some incentive to add that into their work, and it makes it a more affordable service because there is some access for coverage through the government here anyway.
Yeah.
But I mean, my hope is that this spreads, not just to the
Yeah.
individuals who, have to be paid cash, or the services that only certain people can access. My hope is that this is sort of the fuel that ignites a change in the way that we look at sleep and sleep health in every aspect of,
Yeah.
child,
The
the
problem,
child space.
to George's question, the problem is that some health plans in US,
Mhm.
dollars for a 45-minute consult.
Yeah.
So if I
Right.
was going to do a sleep program, I'm going to get $50. The overhead on a pediatric clinic in the US is 60 to
Yeah.
70%. So, $50 times 30 is $15 for my hour worth of time.
Yeah.
There's no way
Yeah.
I pay my mortgage on that. So,
Yeah. Yeah.
so
Yeah.
all this is definitely needed. We need it.
Yeah.
However, the federal government and the state or the provinces, as they say in Canada, in the US, have not properly financed the healthcare of children. And so
Right.
it's
Right.
very difficult to tackle these. To me, this is easy money.
Yeah.
You invest a little bit and you change the trajectory of a whole lifespan.
Right. Right.
But the politicians in the US don't have the courage to do this and invest
Yeah. Yeah.
in our youth today. They rather
Yeah.
they rather pay a lot of money for the elderly to be seen because those are the people that donate to their campaigns, and
I
those are the
see.
people that are organized, and those are the people that turn out to vote.
Right.
That's
Right.
where their bread gets buttered.
Yeah.
And
Yeah.
so that's a problem we have in the US right now. Very sad. Uh,
Yeah. No, for
Sounds
sure.
like a wonderful program. I wish you the most of success. And like I said,
Thank you.
put all the description on our show notes and a link
Yes.
for the
Yes.
listeners to go find you and keep in touch. I'm very interested
I
in how
will.
this grows and as you get put into nurse practitioner and so forth. Do you have
Yeah.
other
Yes.
questions,
Thank you.
George? Any other questions?
No, I'm pretty good. I'm pretty good. I understand.
Okay.
I've seen a lot of sleep training coaching programs. This seems to be popping up.
Yeah.
Yeah.
I always
Yeah.
say medicine is a fashionable thing. Every couple of years, it's something else.
Yeah. Yeah. Yeah.
But
Yeah.
doctors should learn this stuff. This
Mhm.
is bread and butter, Pete.
Yeah. Yeah. No,
It's
for
the
sure.
delivery. It's the delivery that's has to
Yeah.
be adjusted.
Yeah.
And Anya, do you have anything that you want to say that I didn't ask you? I forgot to ask you that you think
No, I mean, I think you touched
conversation?
on everything. Yeah. Thank you so much for your time and for having me on your podcast.
Well, thank you. Thank you. Been very enjoyable hour. And we're so proud with our first international guest.
Oh, thanks a lot.
All right.
All
Stay
right.
stay
Take care.
well and stay warm out there.
Thank you.